Thank you so much for inviting me, and thank you for the introduction. Just realized how I'm going to follow on from the two previous speakers. I think Emma mentioned that biomarker-based diagnosis of dementia in Northern Ireland is actually very low. And Gareth also showed us some kind of CSF sample sizes that are relatively low for the number of patients that we actually see. And I just realized that we're worse. I work at the Maudsley. It's an internationally recognized center of clinical excellence. Absolutely so. And we see about 3,000 people querying cognitive problems every year. So from 2011, when we started looking at our diagnostic rates, we were diagnosing MCI, mild cognitive impairment, the pre-dementia condition in the kind of dementia continuum. We're diagnosing about 1% of our patients, up until 2019, where we were diagnosing up to about 17% of our patients. So about 450 to 500 patients a year. And how many requests for biomarkers, fluid biomarkers, were we getting? Exactly between 0 to 1 per 3,000 patients. And I think that was the main reason why I and Professor Orsland, who's the chair of all-day psychiatry at the college, decided to actually kind of like try to improve those rates. So we started doing roadshows around, and at the Maudsley, with loads of distinguished psychiatrists in our memory services, and we reviewed our results a year later, and we absolutely broke the ceiling with 7 lumbar punctures in 3,000 patients. I can't say that we were super satisfied with it. So what I'm going to be talking about today is a little bit of some piece of research that shows that actually collecting, discussing, feeding back, and using biomarkers, fluid biomarkers, in a psychiatric setting is entirely feasible. It's doable and improves outcomes, patient outcomes. So, the title would be a little bit more accurate if I said that, that we're essentially looking at understanding the feasibility and acceptability of biomarkers in such a clinical setting. And, most memory clinics in England are psychiatry-led. And we are, how should I put it, we're culturally allergic to ordering these things. And, we like to treat behavioral and psychological symptoms of dementia. And we're talking about stages of dementia where, patients are simply just far gone and, there's absolutely no chance of reversing anything. So I will be presenting some preliminary results of the study that were just submitted for publication. And this is based on the clinic that we built 2 years ago as a pilot project that was funded by charity, partly by the NHS and industry grants, and Roche very, very kindly, did for the bill for most of the research that we did. Sorry, I'll stay there because the aims of the clinic are really not dissimilar to what other brain health settings in the UK aim at doing. So we really wanted to provide real world, to understand and, share our understanding of the real world evidence of actually doing, providing a biological diagnosis, subtype and understand AD, stratify the risk. And I think I completely agree with Gareth. When we're talking about biomarker counseling, we need to be talking about risk rather than binary communications, yes, no. And of course prevent, because even in the absence of disease-modifying molecules, we can prevent actually at an early stage. And I think that's, should be a take-home message for everybody. We can prevent up to 40% of incidents in the future at the point of mild cognitive impairment. Now, we wanted to clearly provide advice to referrers and also build a research cohort and allow expand our access to patient access to research in a largely extremely multicultural population of South London who are quite deprived. So this is an indicative model of how we thought a remote memory clinic would work. So we are a virtual clinic. We see patients either online or over the phone. We describe the operational design in this paper that we published, and this is an indicative pathway of how we feel that, so essentially the flow chart of investigations and assessments should happen, and also the ideal skill mix in order to provide a clinical, an optimal clinical and academic interface. Now, I'll talk a little bit about this study because our aim, as I said, was to establish the acceptability and feasibility of these fluid biomarkers, but also establish whether our patients can actually have assessments and be followed up online or over the phone. And we wanted to actually understand whether we're actually providing, we're improving clinical outcomes, including time to diagnosis of dementia and its severity in our clinic versus those the conventional memory services. I do actually have results because I don't have them in my slides. Just received them yesterday, actually. So we diagnosed about 2 years earlier than the rest of the memory services in our own trust. Now, what do we actually do? Of course, we do lumbar punctures, and these are strictly under a research protocol, I'm afraid. We're using the Alexis platform to process CSF samples, and of course, we're documenting the sampling process and the patient experience, right? Now, of course, we're using polygenic risk scoring. We are sampling blood plasma. We're not doing anything with it at the moment, but we're storing it for obvious reasons. And we're, of course, also carrying out remote cognitive and functional assessments in high resolution. And by that, I mean we actually send tablets to our patients who do cognitive and functional assessments whenever they want, even over a week at a time, actually. Primarily looking at using cognitive assessments that cannot be learned. And of course, we're enhancing the pathway with using volumetric MRI software. And it's just software. It just needs to be calibrated with the MRIs, and it's super easy to do. We're also researching ECG, and very importantly, we need to understand patient experience. In terms of interventions, again, even outside, even if none of these molecules are approved, and we think they will, we're looking at prevention, and the cognitive well-being groups and lifestyle management groups are psychology-led groups that are looking to essentially find what are the modifiable risk factors for each patient and try to reverse them over time. So we're working with GPs and families on that one. Now, this was our initial sample size, 60 patients with MCI, with a minimum of 30 participants. This has been increased to 120 patients and 60 LPs, and we've just submitted an amendment for 200 patients over the next 4 years because our clinic was decommissioned in late August of 2023, and we're starting again with research grants. The inclusion criteria are exactly the same inclusion criteria that our clinic uses, so we actually receive referrals from the memory services for patients with a diagnosed mild cognitive impairment. And we do make, nowadays we're also making a bit of we're deviating, not from the protocol, but in the actual clinical operations, we're actually seeing patients with a suspected AD when the biological diagnosis cannot be made. So we know we're a vessel for CSF biomarkers. We are, sort of in a way doubling up as a lumbar-puncture clinic as well. Now, in about a year and a half, we saw about 150 patients. Of the 68 participants, about 66% consented to an LP, and that's about 36% higher than sort of the average research numbers. And I think there is a reason for that. There is, clinicians who are close, who have assessed patients, and who have a familiarity with patients who are asking for a lumbar puncture under a research protocol, as opposed to researchers who may sit with a patient for about an hour or so, and most of the times they will say no. We attempted 26 LPs. We actually had 3 failed ones, and we're talking about lumbar stenosis, really, pain, and then sort of needle phobia. Most of those who actually had an LP were amyloid positive, 65%, and about 55% were also tau positive. It's a 10% that's in between, and I think it's worth discussing a little bit later. So for those who had a positive CSF profile, both in the protocol and in our clinic, we decided to follow up. So we'll be following them up every 6 months. And even though the median, the average time for consenting patients for CSF was about 60 days, the labs that we're blessed with return our CSF samples within about 24 hours, which sort of it's unprecedented. That doesn't even happen in Amsterdam in the Shelton's clinics, essentially. So I don't know that this is replicable. Okay. And finally, this is what our commissioners, the funding bodies, and our managers really wanted to know. So what's the demographic spread, essentially, of those who consented to LPs? We're in South London. It's super multicultural, as I said. And the sample of people who actually said yes were entirely reflective of the population that goes to a memory clinic, and we're super happy about that one. So we're talking about BME populations of primarily secondary education. So less, it was not what we were expecting, wide, well-educated middle class. So, and there was also no demographic variation in those who consented to LP, which was, sort of, again, something that pleased those who we were trying to convince to essentially adopt this in the future. Now, again, that's the full cohort, and it's fairly representative of an NHS memory clinic. So both in terms of age and gender, with a higher percentage, of course, of ethnic diversity, and again, lower education. So of the 135 patients, the majority were able to complete a virtual assessment, about 73%, and about 27% were actually did the assessment over the phone. Now, crucially, 30% of our patients were actually not given a diagnosis of a neurodegenerative disease. So we were super happy, they and their families as well, to be discharged to the GP. So it was a MCI that was not progressive. The cognitive staging of the cohort showed that about 78% of the clinical cohort, 78% had MCI, and about 90% had an actual dementia when they presented to us with a diagnosis of MCI. And there's similar proportions in our research numbers as well. So 82 having an MCI, and about 15% having a dementia at the time of measurement. And finally, again, this is something that we tell our colleagues, all the clinicians we talk to, and of course, commissioners and managers. It's acceptable. We didn't have any. The one SAE that we had, a serious adverse event, was entirely unrelated to the lumbar puncture. So there was no unexpected safety incidents, and generally, people were actually very satisfied with the process. And this is a good enough sample, actually, in terms of, sort of a qualitative research sample. So we're actually quite happy about this. Of course, we're going to continue to expand the samples. And then, very quick case study here. What does this show you? I'm going to be very, very quick. It shows 1961. So this is a patient of ours under a research protocol. He's 62 and obviously has a diagnosis of MCI. And you can see their profile. I'm going to, if you can't read, I'm just going to say it. They have a positive biomarker profile. So what do we do? What would you do if you needed to actually do a session of biomarker counseling with a patient and their families? I think it's not a trick question. The correct answer is actually nothing. You can't do anything with this if you don't understand the clinical context, if you don't understand the presentation, the clinical history, if you don't consider imaging, and potentially even either neuropsychology or, of course, the cognitive assessments. I think this is really, really important, and this is why we're discussing kind of, essentially sort of a risk-based biomarker feedback. In this case, we're talking about early onset dementia here. But the patient received the diagnosis of an MCI due to Alzheimer's disease, which is, again, a research diagnosis, when it's not an ICD-10 diagnosis. Whereas the 70-year-old female who I actually saw this afternoon around 3 or 4 o'clock with her daughter, sort of has all the information that, one needs, including, of course, her initial assessment by a specialist. So she had this telephone-mediated cognitive assessment along with the Addenbrooke's scores. We actually did a neuropsychological testing that showed impaired verbal and visual memory primarily. And we're talking about the 79-year-old who's fit as a fiddle. She's extremely, extremely healthy and generally quite anxious about her cognitive impairment, and someone who's, sort of a very active member in her community. So she's very much on the cusp for CSF biomarkers. So we needed to understand all this in context. Her IQ code is just about marginal. HADS is something that we use the hospital anxiety and depression scale to communicate with each other rather than with patients about anxiety and depression. I certainly don't trust them clinically. And of course, an MRI that showed that had an MTA score between 1 and 2, and some hippocampal atrophy, right? And these are the results. So, for those who potentially work with patients who are cognitively impaired, this is not entirely clear-cut. But at the same time, based on the history and what we've learned to potentially interpret a little bit better is the ratio of p-tau versus over amyloid 42. So we've given the patient a research diagnosis of MCI due to a disease which is called Alzheimer's, but it's not a dementia yet. She has a negative beta amyloid, but the rest of the history is clearly suggestive of an MCI that may progress. And why are we doing this? Because based on our, sort of the operations of our own clinical setting, we're able to now follow her up. She'll be one of the first potential candidates for disease-modifying molecules, the new drugs, if they're approved. And she's going to be receiving all the sort of psychosocial intervention that we can provide in order to potentially even slow down the process. And finally, a little bit about the future. Sort of, we're already, of course, talking about this and whether we have the capacity to accommodate very, very expensive treatments. And I think brain health settings, early diagnosis hubs are going to be essential. Fluid biomarkers are going to be central. I think we probably may need to change our operational diagnosis as well, because research, MCI is extremely too heterogeneous for clinical use at the moment. And of course, consider predictive models. So essentially, group together all the different biomarkers that we use, put them in a black box, shake them, use AI, and try to understand whether the models that we actually come up with are explainable. This is happening, but we need bigger samples. And finally, the blood biomarkers. We've been promised blood biomarkers for a few years, and we're coming actually much, much closer. There are a few that are approved, and many others vying for approval, both here and in the US. And I'm very much a proponent of blood biomarkers, primarily because they're so much cheaper, so much easier, less invasive, and clearly much more scalable. And at the moment, with lecanemab in the US, specialists are entirely inundated with requests for specialist assessments and infusions and all that, and the numbers are going to be picking up. And of course, the potential candidates for disease biomarkers, for disease-modifying molecules, are way too many, and we'll need to find a way to screen patients in and out of the pathway. So there's two opposing camps at the moment, but they're essentially complementary. But there is researchers and clinicians who suggest that they should be placed in primary care, and there is a specific focus in potentially the utility and acceptability of blood biomarkers in primary care. Now, at the moment, there's quite a bit of research that's going on in primary care with blood biomarkers for a very good reason. We need to know the spectrum of functional and cognitive impairment in patients that primary care physicians actually encounter, because they're very, very different from those that we actually see both in our memory services, but also in our research cohorts. So we're talking about people who have a much sort of wider range of comorbidities, whereas when we do research, we actually see quite healthy individuals. So how blood biomarkers are influenced and by comorbidities, and how blood biomarkers potentially even track comorbidities is something that's being looked at the moment. So there are a few studies done both in the US and in Scandinavia, the Biofinder study, Cantate, Sunbird. And there's a few messages coming out at the moment that are actually quite positive. When it comes to the collection, sampling, and storage, things are pretty good. So it's doable. And some tests are actually swayed by comorbidities a little bit more than others. Another sort of, particularly incentive for GPs to use blood biomarkers in primary care is that they're generally very, very happy to screen patients out, tell patients that they don't actually have the disease, which is obviously really, really important. And then the other camp, and I have to say I belong to the VS. It's just in the middle. So the other camp that suggests that actually blood biomarkers need to be done in specialist settings at the moment. And they need to be coupled with specialist assessments along with specialist interpretation of the biomarkers. And I understand this, but at the same time, I think it's entirely feasible to couple fluid and specifically blood biomarkers with cognitive assessments in primary care, and then validate the referrals in the secondary or tertiary settings, but primarily secondary settings in our memory clinics. So we need to understand the diagnostic and prognostic value, again, both in primary care and in memory settings, but primarily in the real-world populations of primary care. And I think that, we're being promised sort of routine blood sampling in the next year or two. I think we're certainly going to be using them, and I think that's the end of, again, a very short pipeline of what's probably going to happen in the next year or so. And these are obviously my colleagues. I want to thank you so much for your patience.